they just stand there, or they really just, you come up to them, they don't talk at all, so catatonic stupor. And also, if someone just behaves really weird, they're just doing odd things, that kind of falls under that category. So, and the antipsychotics work for these symptoms. The negative symptoms is what the antipsychotics don't really improve. And these are the ones that people kind of battle with. And with psychiatry, I don't know if anyone's come across it, we talk about kind of the recovery movement, but we don't aim for cure, we aim for recovery. So we want people to get good quality of life and function back rather than be perfect and back to baseline, because that's not really possible. So probably the most prominent of these, and psych doesn't have too many buzzwords, but restricted and blunted affect probably are good buzzwords. So they kind of, people with schizophrenia have diminished emotional expression. So yeah, they've got poor non-verbal communication skills, and this includes stuff like eye contact, and they're just a bit difficult to engage with. The speech is very monotone and doesn't intonate, and it doesn't really react to what you're talking about. And they're kind of really characteristic of schizophrenia. Other ones are avolition, so this is when you don't really have the motivation to do kind of day-to-day activities, and this is why they're usually unkempt. And this is being recorded. It is? Okay, I was going to say something, I won't now. No, they talk about the schizophrenic smell, but anyway, that's something you'll meet if you meet it. So yeah, they don't really groom themselves, and kind of ask them what's going on in the future. They sort of say whatever. They don't seem to have that motivation. Allogia, so yeah, poverty of speech. They don't really talk a lot. Anhedonia, which I'm sure you're familiar with from depression, so they don't really get enjoyment or pleasure from activities that they used to enjoy. Asociality. So yeah, they're socially quite poor. They're not really interested in having social relationships. And this kind of extends to sexual relationships as well for a lot of patients. And cognitive decline is probably a feature of schizophrenia that we don't talk about enough. And yeah, it's quite early on when it comes on, before the first psychotic episode, and doesn't really tend to, people who've had 10 recurrences and people who've had a first episode seem to be quite as bad as each other. And that obviously makes treatment more difficult and trying to understand the illness and remember things and engage with the psychiatrist and psychologist who manages you. So the course of schizophrenia, it is a chronic illness. Most people have pre-morbid kind of signs. So these are schizoid or schizotypal personality traits. They're just really quiet and reclusive people. They probably don't have many friends and they just keep to themselves or do weird stuff. Then most people exhibit a prodromal stage, and this tends to extend for a few months or even a few years in some cases. And this is when their family probably notices that, you know, they become a bit withdrawn, or they're not quite themselves. Something's a bit odd. They might start doing kind of odd things and having a few weird beliefs, but not to the stage where you kind of think they're psychotic. But it can be a good indicator in the future of when a relapse is about to occur. So the first psychotic episode, that's the first presentation. That's their first delusions or hallucinations or whatever. And this tends to occur between 20 and 30. Women tend to have a bit of a later onset when they go off their nut. Men tend to do it a bit earlier. And then recovery is what we aim for. So this is a very gradual process. Hopefully we need antipsychotics really to achieve this. Very rarely do they kind of resolve on their own. And a sort of sad thing about it is they never really return to baseline. That's pretty unusual. They're usually worse off than they were prior to presentation. And lastly, we have relapse. So around 80% is the figure up-to-date date gave me of within 5 years, 80% of people will relapse. So that's a majority of people, and that's usually requires hospital admission or altering medication, which has its own risks within itself. You can see it's kind of a sad story of recovery and relapse for the rest of their life, and we're sort of aiming to get them out there and going to have some kind of quality of life and maybe be able to work and have social relationships and such. So management kind of comes down to a few sort of different aspects. So psychoeducation is really important in schizophrenia, making sure people understand the illness. They usually, well, it's not uncommon to not have insight. So making sure they kind of do recognise the signs of prodrome and deterioration and stuff like this is also good. Particularly with the family, as well, because the family will manage a lot of these patients for you. They'll have a large role in their management, so getting them on board and having them understand. So psychoeducating the parents and the family, not just the patient, is important. Psychotherapy in schizophrenia. They say you need to do it for like 3 to 5 years, and it's slightly helpful in preventing relapse. So, okay. I don't know how accurate that is. In management, we kind of tend to prefer the atypical antipsychotics. So we'll go through a bit of psychopharmacology in a bit, but they're obviously got a favourable adverse effect profile. So we use them. They're our first line management step. So antipsychotics, we start off with oral, and we need around 1 or 2 weeks to get a response, any kind of response, and we'll try and review the patient within 2 weeks to kind of see is there a response and have any adverse effects occurred. And if that's the case, then you're probably going to want to swap to another one because patients won't be compliant if they can't cope with the adverse effects. So that's probably the biggest reason for kind of issues is non-compliance. So once again, psychoeducation and monitoring the patient closely is very important. And yeah, you need around 4 to 6 weeks to kind of get the full response. If you haven't got a full response by then, there are some, the psychotic symptoms have improved, but they haven't fully resolved, then you probably want to try something else. Try another drug, that is. Or maybe even increase the dose, because it probably should have by then. And yeah, as I've mentioned earlier in the lecture, the antipsychotics are much more effective at treating the positive symptoms than the negative symptoms. Olanzapine and clozapine are probably the exceptions here that seem to have some kind of effect on the negative symptoms. So depot antipsychotics are a very useful tool. So these are intramuscular injections, and they're great for kind of those patients who do have absolutely no insight and fly off the rails, and you're trying to get them to see treatment in the community on treatment orders. So cyclopentixol and flupentixol, they're only used as depots. So if you get this in an OSCE stem or someone does mention this, you know straight away that you're dealing with someone who has compliance issues in the past, and then you can start thinking about reasons why that might be. And probably don't give them clozapine or an oral antipsychotic as your management, because they probably won't stick to it. Haloperidol, paliperidone, and risperidone, they're also used as depots. So these require 2 to 3 months to achieve steady state concentration. So you need to kind of bridge that time period with oral antipsychotics. But once 2 or 3 months is over, then you're good to go just on the depot. All right, so this is psychopharmacology. So we think psychosis is caused by deficiency dopamine, because that's how all our drugs work. So yeah, we think it's increased, deficiency, too much dopamine in the mesolimbic and mesocortical pathways. I'll talk about them in a bit. So dopamine is a monoamine transmitter, and it binds to the dopamine receptor. So it's involved in 4 kind of major pathways. The mesolimbic pathway is in reward, and probably where delusions come from. So drug addicts seem to enjoy this pathway. The mesocortical pathway is involved in cognition and emotion. The nigrostriatal pathway we're probably all familiar with in Parkinson's. So this is a large source of the side effects that arise from antipsychotic treatment come from the action in this pathway. And the tuberoinfundibular pathway. So dopamine inhibits the secretion of prolactin in this pathway. So our kind of target for treatment is the mesolimbic and mesocortical pathways, and unfortunately we also affect the other 2, which is not good. So antipsychotics, they're dopamine receptors, or specifically D2 receptor antagonists, and we divide them into typical and atypical. So I've got a list of a few common ones there, but there's a lot more. These are probably the 2 that you need to know. So the division into typical and atypical, it kind of varies depending where you read, but sort of the typicals are associated with extrapyramidal symptoms, whereas the atypicals aren't. Or they still cause them, but nowhere near as frequently. They're more associated with metabolic adverse effects. However, that's probably not an absolutely true distinction. I think the atypicals are just what we kind of discovered later. It's kind of what it's become. So the adverse effects of, well, all the CNS drugs is they're all over the place. They seem to have affinity for just all different types of receptors, and that's where all the side effects arise from. So for the antipsychotics, they sort of cause extrapyramidal symptoms in the nigrostriatal pathway. They cause hyperprolactinemia when you remove that dopamine inhibition from the infundibular pathway. Neuroleptic malignant syndromes are a fatal syndrome that can arise from treatment with antipsychotics at any point during the course of treatment. And on the right there, I've just got, there's some kind of receptors that it affects that cause some of the side effects. Each antipsychotic has its own sort of affinity profile for these receptors, so they cause these to a different extent, and we'll go through the famous side effects for each antipsychotic in a sec. So the extrapyramidal symptoms, as I mentioned, antagonism of the dopamine receptors in the nigrostriatal pathway. So we kind of divide them into four sort of different symptoms. So acute dystonia, they're, as you can read, brief or sustained muscle contraction. We kind of get worried about these when they infect the larynx and you can't breathe. So they can kill you. If you see someone come in with antipsychotics and they can't breathe, that's always something to think about. Akathisia, so this is a sensation of restlessness. I think some questions ask you to kind of distinguish between this and psychomotor agitation, which can be a bit hard. You kind of really need to use a history. And if they're on antipsychotics or if they've got Parkinson's, let's say, then this could be a cause. Parkinsonism, so you just get signs of Parkinson's. And tardive dyskinesia. This is a particularly bad one because we're not great at treating it. All the others will cease when you withdraw the treatment, but tardive dyskinesia might not. It can even get worse when you withdraw the treatment. So it's a bit of a tricky one to treat. And these are kind of just these movements of the tongue and mouth that the patient can't control, and they can really have a massive influence in their life if it's severe. So we can manage a few of these. So acute dystonia and Parkinsonism, we can manage with benztropine. Akathisia, we just use beta blocker or propranolol. And they will all just improve once you stop the antipsychotic treatment. So it's really a question, and if you get asked this in NOSCI, it's about really weighing up the pros and cons of stopping the treatment. If someone does have severe paranoid schizophrenia and they're going to probably kill their neighbour or something, like you probably will endure some of these symptoms. But if it's a very mild thing and that, you know, they don't have a tremendous history, maybe you do think about changing drug, which may not be associated with as many side effects. So hyperprolactinemia, we've kind of gone through that really. So you just get increased secretion of prolactin. This will present as gynecomastia, amenorrhea, and galactorrhea. They can be a bit trickier to pick up in men. They also get a bit of sexual dysfunction. They get loss of libido as well, which can happen. But an exam question would typically be a woman who's not having periods that's on an antipsychotic. And once again, there are a few that are famous for that, which I'll go through. So neuroleptic malignant syndrome, there's a few of these kind of weird reactions that happen. So like serotonin syndrome and lithium toxicity, they all kind of look a little bit similar, but we're over all of them. And usually the history is kind of very good at directing you. So this will obviously be someone who presents sort of like this, who's on antipsychotics. So it's idiosyncratic. We have no idea why it happens or when. It doesn't really make sense. It tends to occur when you're changing the dose of your antipsychotic or you're changing the type of antipsychotic. So you seem to be a bit more vulnerable during that initial period. And it presents with mental status change. This is usually like confusion. You're a bit confused and not quite aware, not orientated. Muscular rigidity, that's a big one because your muscles start to break down. You go into rhabdo, and pigment from your, I forget the pigment, it's myoglobin or whatever, it's nephrotoxic. So you're in a renal failure and you die. It's not fun. Autonomic instability and hypothermia. You get very high temperatures and they need to cool you down in the ICU and stuff. So it's a very serious reaction that can happen, but it's something we kind of prepare for and should all know. So these are kind of, I've stolen this from ECG, the sort of relative side effects caused by each of the antipsychotics. Yeah, you can read that in your own time, I guess, because on the next slide we'll kind of go through what drugs are famous for. So all of the typical antipsychotics, they're really known for extrapyramidal side effects. Clozapine and olanzapine seem to cause the metabolic side effects. So these are your weight gain, your hyperglycemia, and your dyslipidemia. And in fact, the life expectancy in schizophrenia is not too good if you've been on antipsychotics for a long time, because you die of stuff related to metabolic syndrome, like AMIs and such. Paliperidone and risperidone, they're involved in hyperprolactinemia, and quetiapine is involved in sedation. It's got action on the histamine receptor, I think. It's actually becoming a drug of abuse. I think how people abuse benzos now is how we'll abuse quetiapine in a while. It's called Susie Q on the streets, if anyone cared. I like the name. So yeah, these is a very important thing to know. I feel like this slide, this could be an OSCE station on starting someone on a drug and counselling them, and then it comes up in EMQs a lot. We'll go through a few EMQs in a little bit. There's no real way to kind of think about it. You don't have to be intelligent to understand this. It's just simply remembering which ones cause what. And yeah. So clozapine is a special one. It works better than all of them, but it's very dangerous and can kill people. So we use this in treatment-resistant schizophrenia, and there are a few other indications, but if you've tried 2 or 3 drugs and you're still really not getting the recovery, the quality of life back to where it should be, and you've still got distressing psychotic symptoms, then clozapine is kind of the drug we try. It has the highest efficacy and very low incidence of extrapyramidal symptoms. What we worry about is agranulocytosis. So 1% of people will get this. So when you have no immune system, you get an infection, you die. So the kind of classic EMQ is someone comes in on clozapine, what do you order? They've got a fever, FBE. And you should monitor people on clozapine with regular FBEs anyway. It can also affect the heart, particularly myocarditis. So you do an ECG and echo at baseline prior to starting the treatment, and then you monitor regularly to see any changes that arise. Once again, it can kill them, so stay on top of that. And it's like olanzapine is very famous for the metabolic side effects, so you need to monitor their weight and blood sugar levels and lipids throughout the course of treatment. Because once again, this tends to be the leading cause of death in these people. It's got some quite prominent anticholinergic side effects, like quite severe constipation, people on clozapine. It's very sedating. It's so sedating that you so anticholinergic side effects include urinary retention, but you get nocturnal enuresis, you start bedwetting because it's so sedating that you just kind of lose control. You're not aware that you need to go to the toilet, you don't wake up and you just wet the bed. And also, drooling a lot at night time particularly. So it's a bit of a life-saving drug, really. So in 30% of people who otherwise wouldn't be able to treat, it seems to work and give them good quality of life. So it's a great drug. It's got a few issues, but if people can tolerate it, it's the place to be. All right, so I've got some EMQs here. I don't know if you guys have the slides yet. I don't think you do.
They do.
Nods. Excellent. Does anyone want to answer this? These are just all from the past papers that have been released. Ask the question, just interrupt me. Mine's very casual. Yep.
We don't like clozapine causes heart elevation when it's anticholinergic.
It's because you just leave your mouth open and drool. You're just so sedated. Yeah, okay. It's so sedating. That's why you take it before you go to bed at night, just because it just knocks you out. If anyone else has any questions, please ask. Just put your hand up or interrupt. Anyone want to have a go at this? Hello? Anyone? I want to pick people. Monica, I voted for you for grad rep, so you're going to answer this question for me. Winning by default still counts. So we've got someone with an intellectual disability, so
You're an MCS.
You're an MCS, okay. put to you that like everything you're given in the history is for a very specific reason. So she's been on an antipsychotic for 30 years, so side effects are probably likely to have developed. Thyroid with lithium. So she's been a bit lethargic. Think if this was like a 4-year-old kid who came into ED, he was just like dehydrated.
Yes, urine.
Urine drug.
Oh, cool. Yeah, good. It's probably the hypoglycemia that resulted from just olanzapine for 30 years. And it can be really tricky in people with intellectual disabilities. They love asking these questions in the exam. So yeah, long-term olanzapine. All right, I'll pick someone else to say. So this is probably, someone's already asked this question. Someone who got sedated and hypersalivation after starting this medication. It's the easiest question we'll ask.
Amazing.
Oh, nice. Correct, yeah. So for the reasons we spoke about before.
Yes.
That's all. So we'll start talking about depression.
I'm really sorry.
My back slowly breaks.
I'm really sorry.
I'm having fun in this position. I'll move the table.
It's just in front of you as a button.
God bless you.
Did I say a secret? So confused.
Haven't you leased some life?
It's on. No, it's
All
on.
right. So depression. This is probably like the big topic in this subject. It's a really, really common. I think it's like 10% in your lifetime will have it. 12%, I think, in Australia. So it's good to kind of know how to diagnose it really well. So you need just, well, the way I think about it, I kind of divide the symptoms up into somatic and psychological. So the somatic symptoms are weight and appetite changes, changes in sleep, excessive kind of fatigue or daytime tiredness, loss of energy, and psychomotor changes of any kind. These are really non-specific, perhaps with the exception of psychomotor activity. So like anyone will present probably with fatigue with any illness or maybe a change in appetite. But if they are prominent as part of kind of a depressive syndrome, then you're probably dealing with a more severe kind of depression. The psychological symptoms, you need to have 2 of these, so depressed mood and anhedonia. They're required for a diagnosis, one of. And there's feelings of worthlessness, impaired concentration, and suicidal ideation. I feel that sometimes people can kind of get to 5 symptoms and they go, oh, you meet the criteria for depression, good, let's keep going, let's move on with this history. But you should always, always, always ask about suicidal ideation, just because it's exceptionally important. You don't want people to kill themselves, but also because it kind of really guides your management. If someone has suicidal ideation, they're automatically severe depression, so you know where to kind of go with that. And once again, depression, major depressive disorder is just you've had a major depressive episode and nothing else. Like, that's all you've had. You can only have one and have a major depressive disorder. So the duration of a major depressive episode tends to last for 20 weeks. And this seems to be independent of treatment. The antidepressants just treat the symptoms of depression. They don't actually fix the depression itself. So if you have any life stressors or anything else going on, that will not improve it. One nice thing about them is they kind of improve you to a point where you can kind of engage with psychotherapy. So yeah, they last for 20 weeks, and that's kind of the logic behind why we treat for another 6 months to a year after we have treated the symptoms. So the course of the disease can there are sort of 3 patterns. This is in my mind, I haven't read this anywhere else. So there's a recurrent course, and this is a typical one that most people have, where you have depressive episodes and you'll have them for the rest of your life, but in between them you seem to be okay. You get a full resolution of symptoms. The persistent one is rather unfortunate, where you kind of always sort of depressed. The symptoms never fully abate, but you do kind of get on top of them. And the rare one is probably isolated, where you have one major depressive episode and that's it. So you consider yourself very fortunate if you fall into that category. So management kind of comes down to 3 things plus considering ECT. So psychoeducation is always important in any kind of psychiatric illness. You'll get a mark on the OSCE just for saying it. It's the easiest mark you'll get, probably after washing your hands. And then we have psychotherapy and pharmacological therapy. And we kind of, depending on the severity, gauging severity is it should be easy. Like, if someone can kind of go to work and still do all the stuff in life they want to do, but they're sort of upset and not, I don't mean to sound belittling when I say that, but they can really just sort of carry on with life, then that's a mild depression. A severe depression, if they're having like suicidal thoughts or they're not getting out of bed, they're just bedbound, and that's severe. It can be a bit tricky to gauge moderate. And the efficacy of treatments seems to depend on the severity of the depression. So in mild, psychotherapy works much, much better than antidepressants. In moderate, they seem to be about the same. And in severe depression, you need antidepressants. You won't get better with just psychotherapy, and you likely can't engage in psychotherapy anyway. But that being said, doing both is best. The reason we don't do it for everyone is because the drugs have side effects, so we'll avoid them if we can, because they're likely just placebo anyway in someone with mild depression. And by the way, ECT is a really good OSCE station, but we'll go through a bit about ECT later. Just kind of counselling a patient and telling them that they're not going to get their brain fried or anything. So psychotherapy, these are really annoying questions on the exam. So we do this for everyone with depression. It's indicated in everyone, assuming they've got the intellectual capacity to kind of engage and the drive and motivation. So 2 sort of ones that we use, well, the 2 that we use for depression are CBT and IPT. We'll go through them individually. They're the only ones with efficacy proven in depression and the most studied. So I feel like this is probably as much as you need to know about psychotherapies, maybe even a bit too much. So you do 12 to 20 weekly sessions. The government will only pay for 10, I think, but 6, and then you'll apply for another 4, so it's a bit stupid, but it's the way it is. So CBT kind of works on the premise that you're having maladaptive thoughts and behaviours, and they kind of fuel each other. So this might be something like, oh, I'm so stupid, I'm not going to pass this exam. And then you go to the exam, and these thoughts influence your behaviour and the way you do the exam. And then that kind of reaffirms your thought you had originally. So it's kind of a cycle, and they build up. So CBT tries to kind of identify them, see where these bad thoughts and behaviours are. It challenges them and then tries to modify them, and hopefully stop doing them, or you change to a better type of behaviour and thought. Interpersonal psychotherapy has a bit of a different objective. This is done over weekly sessions. It's a little bit shorter than CBT. So 12 to 16 in this case. And it kind of believes that interpersonal issues are the source of your depression. So you've had an argument with your boyfriend, or you've had some kind of life issue that you need to sort out. And this just, once again, identifies and gives you strategies to, well, once you identify it, you can either fix it, or it will give you strategies to cope with stuff that you can't modify. That's about all you need to know. Psychotherapy, treatment of depression. The pharmacological therapy, this is only for moderate and severe depression. We use antidepressants, and the first-line therapies are SSRIs, SNRIs, and mirtazapine. We'll go through psychopharmacology shortly. A lot of psych questions are psychopharmacology, so it's probably the only field where you need to really know the pharmacology back to front, because it's like half of your exam questions. The antidepressants need 1 to 2 weeks to kind of start seeing any benefit, and 4 to 6 weeks to get the full benefit of the drug. So we review the patient at 2 weeks, and we see whether they have improved and how they're going, and also if any adverse effects have arisen. Because once again, if they're not enjoying the drug, they're really struggling with the side effects, they're probably not going to continue taking it, and there's no point. If we haven't got a response at 2 weeks, we probably increase the dose if they can tolerate it. And if they can't tolerate it, we'll change the drug. And afterwards, we continue for 6 to 12 months to kind of prevent relapse into depression. This is an important thing. It's probably like 1 mark on each OSCE station. So during the initial stages of treatment, the the apathy and the kind of fatigue and the can't be botheredness that you have in depression, it kind of goes away before your depressed mood and suicidal ideation improve. So this can kind of equip people with the means to then go and kill themselves because they suddenly have energy and they're a bit more motivated to do so. So this is really important to kind of warn the patient of this, that, we're starting this drug, it will help you, but at the start it will make you feel a bit worse maybe, and safety net them say to come in, and really important. And the same for the kind of gastrointestinal side effects and sedation that antidepressants can cause. They seem to improve after 2 or 3 weeks. Maintenance treatment. So this is once the kind of acute episode is gone. So we can put people on long-term prophylactic antidepressant treatment. And this is for people who've had many, many recurrences, or perhaps even considering those with a very severe episode of depression. So if they've had to have ECT because they're going to starve themselves to death, then it's probably worth putting on an antidepressant long-term. So pharmacological, if the SSRIs, SNRIs, and metazapine haven't helped, then we move on to other antidepressants, and we'll go through each one, and we'll talk about why TCAs and MAOIs at the bottom. So yeah, these are your kind of antidepressant classes: TCAs, SSRIs, SNRIs, MAOIs, and other, sometimes called atypical antidepressants. They kind of work just through random mechanisms that we found. So the kind of monoamine theory of depression is that there's a deficiency in monoamine transmitters. The literature probably suggests that's not the case. That's not the cause of depression, but it seems to be how all our drugs work, so we'll go for it. So serotonin is one of the monoamine transmitters. It binds to serotonin receptors. And once it's released, it gets reuptaken to kind of terminate its action through the serotonin transporter. And this is a big target for our drugs. And yeah, once again, the monoamine theory, is this what causes depression? Noradrenaline is also a monoamine transmitter in the CNS. It binds to adrenoceptors, which I'm sure you're all familiar with. And the noradrenaline transporter reuptakes it after it's released back into the presynaptic neuron. So the tricyclic antidepressants, they inhibit the reuptake of serotonin and noradrenaline in those transporters, but they also seem to love every other receptor, so that's why they have a very wide range of side effects, and they seem to interact with a lot of other drugs. So for a while, they were the only treatment we had. So they worked, but they just caused a lot of problems. And the kind of famous side effect for these is cardiotoxicity, your QT prolongation, which is bad because then you go into ventricular arrhythmia and die. And I put a name of a few up there that you should probably know. They're used a lot more for treatment of other stuff like neuropathic pain and bedwetting. So this is the kind of range of receptors they bind to, and the kind of side effects that result from this. As you can see, there's quite a lot. Yeah, we don't really use them too much for depression anymore, but you might still see them. I'll give you other slides, so don't write anything down or anything. So the SSRIs are kind of the number one drug we use now, so it's worth getting familiar with them. So they block reuptake of serotonin on the serotonin transporter, and they're selective for it, so they block that and not too much else, which is good. It means there's less side effects. And one of the kind of adverse effects unique to the SSRIs are, not just to them, but other things that block serotonin reuptake is increases the risk of bleeding, because uptake of serotonin into platelets also occurs by the SERT, and that's needed for to stop bleeding. So yeah, it's mainly the side effects that come on with these are just from serotonin receptors, not from anything else. As you compare that to the TCAs, which have all that. So they're a much nicer drug. The main issue is sexual dysfunction, and it actually stops a lot of people taking it. So yeah, it's just once again important to counsel people when they start that sexual dysfunction is one of the side effects, and if it does occur, then try and change to another drug. And the gastrointestinal side effects are slightly nausea and vomiting and diarrhea, but they seem to improve in a few weeks. So the SNRIs, these are sort of like the tricyclics, where they block the uptake of serotonin and noradrenaline through their transporters, but they seem to only they're a bit more selective for them compared to the TCAs, which will affect everything else, but they seem to more readily affect them. There's only three of them: duloxetine, venlafaxine, and desvenlafaxine. I haven't seen them used too much, but they are. It's just got a favourable adverse effect profile to the TCAs, and they're first line now, so you can use them instead of an SSRI if there's any indication for that. And there's just, once again, their adverse effects. All right, so MAO. This is an enzyme that you find in cells everywhere, and it catalyzes the oxidation of all of the monoamine neurotransmitters, or transmitters. So they get metabolized and obviously effectively removed from the system, reduces the amount of them that are present. So there are two isoforms, and they're kind of very clinically relevant. So the MAO-A isoform is catalyzes the oxidation of serotonin and noradrenaline, which is very handy for depression. And the MAO-B isoform is involved with dopamine. So MAO inhibitors are irreversible. You can't take it back once you've done it. And they're non-selective. They inhibit both isoforms of the enzyme, and they're not commonly used just because they have a wide range of side effects. Meclobamide's a reversible MAOI, and it's selective for MAO-A. So it only does serotonin and noradrenaline. The MAO-A only does serotonin and noradrenaline, which is good. It has an advantage in terms of adverse effect profile as well. So the cheese reaction, this is, once again, could come up on an exam, is the reaction that occurs when MAO-A and MAO-B are both blocked. You can't metabolize something called tyramine. You find that in foods such as cheese and wine, hence the name cheese reaction. And it's a sympathomimetic, so you get a hypertensive crisis, and once again, people can bleed out of their brains and die. And it's important to kind of distinguish that this does not occur with meclobamide because you still have MAO-B, you've only inhibited MAO-A. So a typical kind of EMQ could be someone who comes in with this cheese reaction, this hypertensive crisis, and kind of just knowing that phenelzine or another MAO-A can cause this, but meclobamide won't. Reboxetine, so we're on to the atypical antidepressants now. So this is selective for the noradrenaline transporter. So it blocks that and increases the amount of circulating noradrenaline. It's in the literature, it's got a much nicer side effect profile than the TCAs, but it also has less efficacy, so we use it second line. And the kind of famous side effect is insomnia. As you can see, I've bolded that, and there's three pluses. Mirtazapine is a nice drug. We actually use this as first line. So it's an alpha-2 blocker. So just to get my head around this. So when you release noradrenaline, noradrenaline binds to alpha-2 adrenoreceptors on the presynaptic neuron, and this inhibits the release of further noradrenaline and serotonin. So the idea with this is that we block those receptors but don't activate them, we antagonize them, so that there's none of that inhibition that would normally occur when noradrenaline is released. So it is nice, and it's kind of the famous side effect is weight gain and sedation. Agomelatine is one of these newer drugs that binds to melatonin receptors. Melatonin in the pineal gland. So yeah, it's got a big it's good for sleep. It kind of helps you regulate a nice, healthier sleep cycle. We're not exactly sure why it helps in depression. It's got something to do with serotonin. I don't really care enough to know. I feel like we don't know, so I'm not really interested in the theories. It's nice because it's got no kind of significant affinity for the other CNS receptors. So a big kind of selling point of it is there's no sexual dysfunction, which happens with almost all of them. I think mirtazapine doesn't either. The big issue is hepatotoxicity. You should have LFTs constantly while you're on it, or regularly. You should also have a baseline LFT done prior to starting. So this also comes up in EMQs where hyponatremia, it's caused by kind of the four big groups of antidepressants. They all cause it. Not sure why, but it's obviously something to keep an eye out for, particularly in older people. Serotonin syndrome. So this kind of comes about from increased activity of serotonin in CNS. There are a few sort of drug groups that can kind of precipitate it. So the antidepressants are serotonergic, so are opioids, and the stimulants are stuff like cocaine as well. Cocaine blocks the serotonin, serotonin transporter. So a typical kind of EVQ, once again, is you're on an antidepressant, you take an opioid, usually tramadol is the one they go for, and you come in presenting as such, and you kind of just got to pick that. So once again, mental status change, so you usually come in with acute confusion, neuromuscular excitations, kind of a variety of things, hyperreflexia and things like that, increased tone, and autonomic hyperactivity, so their vital signs might be all over the place in the temperature. ECT, as I mentioned before, this could be a good OSCE station, I think, explaining this to a patient. We use this in severe depression, depression with psychotic features, and if someone's really had treatment-resistant depression for a long time. It works by, we just kind of give general seizures to the person. We don't know why it works. There seems to be a change in receptors in the post-ictal phase, but don't know. So this is done on a general anaesthetic, which is a concern most people have. Will it be painful? Will it be scary? No. We also give a muscle relaxant, so that should also reduce the kind of tonic-clonic activity and shouldn't have muscle pain afterwards. And so it's the most effective treatment for depression, and severe depression particularly, that is not treatable by other means. So we should probably use it a bit more than we do. And the typical course is 6 to 12 treatments, and you do around 2 to 3 a week, and you'll start seeing improvement after 2 to 4 treatments. There's a few kind of caveats to using it. So you can't be on any drug that kind of lowers the seizure threshold. So these are benzos and anticonvulsants, quite obviously. They're probably the 2 most common ones we come across. And the common side effects are headaches, myalgia, a bit of muscle pain, and you can be a bit confused afterwards for around half an hour, but that will go away always. The issue and what scares people a little bit is anterograde and retrograde amnesia. So you lose a bit of memory and like your past memory and a bit of your kind of working memory. And this can kind of improve over weeks to months, and it may not improve entirely in everyone. So that's really what patients are frightened of. And we kind of tell them that this is ECT and what might happen. A big kind of selling point, kind of counterintuitively, you think having a seizure in pregnancy would be very dangerous, but with muscle relaxant tends to be quite safe. We just load them up with sucks, and they don't shake too much. So it's really good for treating depression in pregnancy when you're worried about drug concentrations reaching the baby, and also in breastfeeding. So yeah, it's very good in pregnant women. And we also use it in bipolar disorder and schizophrenia that's either very severe or we've had trouble treating. All right, now you guys can do some talking. When someone yell out if you think you can do this. Cool. Why? Yeah, so she's taking tramadol as well. They're both serotonergic, and you get a lot of serotonin and you have fun. So yeah, SSRI. Another question?
Mirtazapine.
Yeah, why do you want to use mirtazapine?
Because all the other ones cause hypernatremia.
Cool, I agree. One thing I just kind of thought of reading it then, they mentioned that he has a poorly controlled history of hypertension. Does anyone think why that might be in someone's severe, I call it severe depression? Why we might care that it is hypertension? No, wrong.
Gosh.
ECT, someone said it, yes. Who said it? Someone there. You? Cool. Yeah, because your blood pressure just goes through the roof when you're having it and bleed into your brain and die. It's not fun. So yeah, just that's why you probably would avoid ECT in this person. But yeah, the big selling point is it's hyponatremia. All right, go back.
Yeah. Why is CBT just not the answer?
Because it's not mild. This is a guy whose life's pretty fucked. Oh, sorry, life's not going too good. He's got a lot of symptoms and yeah. So that's why I wouldn't do CBT. Another question, go.
So what was the other drug that didn't cause hypo? Is there any other?
I can't remember the ones that do and not the ones that don't. So the SSRIs, SNRIs, TCAs and MAOIs, they all cause hyponatremia. So anything else is good. So mirtazapin's the only option to really choose from. Yeah. So yeah, that's why you wouldn't use escitalopram in this guy. All right, bipolar. It's a fun disorder if you've ever seen someone with bipolar. So yeah, we're really after a diagnosis. You're only after someone who's had a manic episode in the past. You don't need to have depressive episodes, even though they are characteristic of the disorder. The diagnosis only needs one manic episode. We kind of classified in two different ways. So bipolar 1 is just you've had a manic episode in the past. Is that the Kim Possible thing? Yes?
Interesting. Yeah.
It was?
Yeah.
Nice, cool. So yeah, they've had one manic episode in the past. And bipolar 2 is when you need to have a hypomanic episode and a depressive episode. You need both of those to kind of meet the diagnostic criteria in DSM. Yeah, we use the DSM for all your EMQs and like OSCEs. That's what you need to use. It's kind of annoying because it's changed recently, so all the past old OSCEs can be a bit wrong, which is a bit confusing when you're trying to prepare for your exams. So a hypomanic episode differs from a manic episode. It's a bit shorter in duration and the symptoms aren't quite as severe. By definition, if you've had psychotic symptoms like really severe delusions, or you've needed to go to hospital because you're out of control, then it's not a hypomanic episode, even if the duration is only 4 days and not a week, like it's required for a manic episode. So what's the course of this illness like? So it can be a really tricky diagnosis to make, and once again, it's a good OSCE station to see whether you're actually thinking and understand things. So people who come in, they might just have a depressive episode, which in that point in time is not diagnostic for bipolar, but around 20% of them will go on to have bipolar disorder diagnosed at some point in time. And a good clue is that depressive episodes will happen like younger in people with bipolar than people with depression. So if you get someone who's 17 or something and nothing catastrophic has happened in his life, it's probably there's a good chance he could go on to have bipolar. It's quite a strong feature. And there's a very strong family history, family link to it. You're 10 times at risk if one of your direct family members has it. And once again, it's characterized by kind of recurrent mood episodes, so either manic episodes, hypomanic episodes, or depressive episodes. So 90% of people will go on to have recurrent mood episodes, which makes a prophylactic treatment of it very important. So most manic episodes kind of precede a depressive episode. If you've ever spoken to someone who's got bipolar, they'll tell you about how the high comes before the fall. They're really feeling great and on top of the world, and then everything goes to shit. And usually during their manic episode, they probably have done something wrong. They've gone and spent a lot of money or damaged their reputation or something in some kind of way, which kind of enhances the depression. And the depression is no different in bipolar 1 or bipolar 2. A big kind of concern in this group of people is suicide, because once again, they are coming from such a high place to a low place, and their risk is 15 times higher than the general population. And once again, they do engage in risky behaviour, so they tend to, 25% of them have abuse or dependence on some sort of substance. Alcohol is a common one, and 60% of them have anxiety. So it's a lot of comorbid things you need to manage in these people as well. Once again, management comes down to kind of psychoeducation plus a few different things. Once again, just explain the course of the illness and the need for management, because even though you feel fine, you will probably have a mood episode if you stop taking treatment. That's the most common cause for someone who's come in with a manic episode. They're probably not taking their lithium, or the lithium's not at the right concentration. So acute mania, as I kind of alluded to before, is an emergency because, well, they're not going to die. They're just going to do something absolutely out there. Just jump into the river naked or something, or they get up to sexual misdemeanors and spend a lot of money. And this really has implications that they're not thinking. At times, not the most evidence-based stuff, but it's pretty good. So yeah, first line, we use an antidepressant plus one of the drugs that we use in prophylaxis. And this is kind of handy because if you start them on the prophylactic drug now, you can just withdraw the antidepressant and continue on the drug they're on. Or you can use quetiapine, which is a sedating, atypical antipsychotic. So we discontinued the antidepressant 1 to 2 months after the depressive episodes improved. And once again, this is because we were a bit scared of pushing them into mania. So prophylaxis, the aim of this is to kind of prevent recurrences, particularly of mania. So we use mood stabilizing drugs. Their mechanism of action is a bit up there. We think that it kind of just changes like membrane potentials, but I don't know is the answer. So the kind of gold standard one that we use for a long time is lithium. We use anticonvulsants with lamotrigine being first line, with carbamazepine and valproate we use as second line. With most atypical antipsychotics as well can be used. Psychotherapy also has a role, apparently. So this is kind of, it won't manage the bipolar, but it can help if you use it in combination with your pharmacological management. CBT is one that's quoted as being good. Social rhythm therapy, I'm trying to remember what this is. I remember this now. So this kind of, the social part alludes to like, if you have some kind of social stressor, once again you break up with your boyfriend or whatever. And the rhythm part's to do with sleep rhythm. They think that these kind of social stresses can affect the like circadian rhythm, and the idea is you fix all that and you're less likely to relapse, which I guess makes sense. And once again, psychoeducation is also very effective in prophylactic treatment. All right, almost at the end, it's good. Mood stabilizers. We've got lithium, anticonvulsants, and antipsychotics, which I kind of alluded to before. I'll kind of only go through lithium because that kind of gets examined quite heavily, and you should have already learned the other two previously. So the mechanism of action of lithium is not known, not absolutely known. One of the common side effects that can occur with it is a fine tremor. You can treat that if it's really bothering the person. Another thing you can do is kind of inhibit the response of ADH in the distal tubule of your kidney, and that obviously results in nephrogenic diabetes insipidus. So if someone's really thirsty and going to the toilet a lot on lithium, that's probably the cause. The long-term kind of famous side effects are hypothyroidism and renal impairment that occur after years of use. And it's also not safe in pregnancy. It can cause Epstein's anomaly, which is something to do with the pulmonary valve. I can't remember what. Some of the cusps like downwards displaced or something. So that could be a potential kind of OSCE topic. It has a very narrow therapeutic index, which makes it a little bit dangerous to use. So you need to have ongoing monitoring to make sure you're in the therapeutic range so you're getting a benefit of it since you're exposed to the risk of toxicity. The kind of classic situation of toxicity can arise from, assuming you haven't overdosed, that's also a big one to consider, but it is dehydration and impaired renal function. So in dehydration, you're obviously losing fluid, so the concentration will rise. And in impaired renal function, you're not clearing the drug yet, you're still taking it, so the concentration will also rise. And the sort of indications for that, if someone's had gastro or diarrhea on the diuretic, then that can obviously dehydrate them. And renal function, again, if they have primary renal disease or they're taking NSAIDs or ACE inhibitors or any other drug that can impair renal function. So typically in Cuba, will just be someone on lithium for 10 years, suddenly goes into lithium toxicity, they just started on a blood pressure medication or something. So once again, it presents kind of similar to the other sort of serotonin syndrome and neuroleptic malignant syndrome. Once again, mental status change, once again, it's confusion. You have diarrhea and vomiting, they're fairly specific for this, not specific, sensitive at least. Yet ataxia, uncoordinated and neuromuscular kind of excitation. And once again, these questions were about lithium toxicity. They're really obvious because it's someone who's on lithium. It won't be someone who's on like an antipsychotic and lithium and an antidepressant, and you've got to try and figure out which one it is. All right, Ian Hughes. So we've got a 55-year-old lady with bipolar. He's tired, gained weight, and is cold. Anyone? Thyroid, yep, cool, I'm happy. So yeah, order of thyroid function. What's this? No. G, cool, I agree. Just lithium toxicity. Probably should have asked these like right after I did it. Makes them really obvious. Is this a more fun one? This is a more fun one.
Yeah.
A fun fact about sertraline, it reduces your risk of having a heart attack after you've had one. So if someone's had an AMI, you give them sertraline as the antidepressant of choice. True story. C? Oh, let's see. Stop sertraline. Yep, why are you saying that? Yeah, so why don't you just treat the mania? Yeah, correct, because that's probably what's caused it. Good. Okay, decrease sertraline. Well, I suppose some psychiatrists would agree with you, but the guidelines say not to use an antidepressant on its own in someone with bipolar. So if you were to decrease sertraline and start something else that's used, like start lithium as well, that might be the right answer, but it's not one of the options. Are you asking me about doses?
Yeah, it's a really small dose.
Okay, I'll take your word on it. I don't know doses, I'm not going to pretend I do. So yeah, if that's a really low dose, decreasing it's going to be a waste of time. But anyway, the answer is just stop it, so cool. So yeah, you just got to stop the cause, the mania in this case. So psychopharmacology, as we're heading towards the home stretch here, we're doing well. These are kind of the psychotropic drugs that we use. So we've gone through antipsychotics, antidepressants, and mood stabilizers. We'll run through anxiolytics and then do our super duper fun OSCE station. So the anxiolytic drugs they're good fun. We don't use them as much anymore because people become addicted to them and abuse them. So the two kind of classes you need to know about, the benzodiazepines and the non-benzodiazepines, which are the Z drugs, as some people call them. So they kind of are involved with the neurotransmitter GABA, gamma aminobutyric acid, and it's inhibitory. It inhibits, it's like universally inhibitory, whereas the others sometimes are excitatory and sometimes inhibitory. So there are a few GABA receptors, but the main one is GABA-A, and that's a ligand-gated chloride ion channel. So when GABA binds to it, the permeability of the channel to chloride increases, so it just lets chloride in, just like a gate opens up. And what happens is chloride goes in, and you get hyperpolarization of the membrane, and you can't fire action potentials, so you get inhibition of nervous transmission. So the benzos, It's probably worth knowing the kind of half-life of them. Like knowing that midazolam is really, really short-acting. That's not the half-life, by the way. That's the duration of action that I've got on the screen. Because sometimes EMQs can ask you to differentiate between them, and it's helpful to know in real life when you're having to sedate people in ED in a few years' time. So the benzos bind to the benzodiazepine site on the GABA-A receptor. So that's different from where GABA will bind. That causes a change in the shape and acts allosterically. So what it does is it increases the affinity of GABA for the GABA receptor. So more GABA will bind to the GABA-A receptor, and you get increased frequency of chloride channel opening and increased inhibition. So that's quite a few fun effects. So it's anxiolytic. It used to be used to treat anxiety, but now we use it SSRIs. It's hypnotic, so it puts you to sleep. It's used in like induction of GAs, muscle relaxant and anticonvulsant. So it'll stop seizures, use it to treat status. And you have to stop it before having the ECT. So the adverse effects, like this first dot point is kind of common sense, because like how the drug works, it obviously makes you a bit drowsy and slows you down, slows your thinking down, you get a bit confused. Your working memory goes, and it can become a bit not so stable on your feet. So people have falls risks when they have benzos. It's quite good in terms of you can't really overdose on them. So the barbiturates were the drugs that kind of work similarly to the benzos that we've stopped using since we invented benzos. So with barbiturates, as you took more, you would just slowly stop breathing and die. But these seem to kind of taper off, so I don't think you can actually kill yourself on benzos. The risk is that people don't tend to only have one poison, they abuse more than one. So any other CNS depressant in combination can cause respiratory depression and death. Alcohol is probably the common one. And the reason that we don't use these as widely anymore is because of tolerance and dependence. You'll see a lot of old people in the community who have been taking the same dose of benzos for like 10 years that probably are doing nothing for them, and they can't stop taking them, or they'll just like start withdrawing. And non-benzodiazepines, called the Z drugs, so we'll start with Z, or Z. So these bind to the alpha-1 subunit of the GABA-A receptor. So the benzos bind to the benzodiazepine site, and that's got a few of the subunits, one of which is the alpha-1 subunit. But these Z drugs, they only bind to this alpha-1 subunit, and it turns out the alpha-1 subunit's involved with hypnosis, the hypnotic effects of the benzos. So it's kind of nice because it gives you an opportunity to only get hypnosis or a hypnotic effect without the anxiolytic muscle relaxant or anticonvulsant effect. So the idea is that they're safer than the benzos. It's used as like a sleep drug to treat insomnia. But we get a lot of people like on the news that take like still knocks and drive and crash their car and kill people. So I don't know if they're that much safer. All right, we're going to take a break now while I set this up for like a minute. And we're going to need volunteers. It's not a hard station, it's a fun station. And it's good practice because video stations are really a bit tricky to kind of prepare for. It's a station from 2012, so it's a real station.
It's a real station.
No, it's been released to commercial. Yeah, I was like, oh, actually, maybe.
Don't. It's actually bad. Yeah. one. No. Ah, it's because it came up with okay.
I think he's going to get people to do parts of the MC.
Alright, hello, welcome back. I want to go home soon, and so do all of you. So this is a video station that's a real OSCE in 2012. And in 2012, the OSCEs went a lot longer. So it wasn't a video station, it was a station you were meant to do. So you have to take a history from this guy, whose name is Chase. And he's having some difficulties putting on a pillowcase, as we'll see soon. Anyway, I've got a nice volunteer on the video called Ian to do it. So he'll do the interview. And this station asks you to kind of formulate a diagnosis, to just say what you think the diagnosis is and give one or two differentials. And also report your MSE findings and a risk assessment for this individual. So does anyone want to do any of that? We can kind of split the MSE up. I've done it last night. It was pretty fun. It'll be good as well, I promise, guys. I'm going to start like giving people jobs now. Alright, you guys at the front. I'm just going to point to people. You're going to do appearance and behaviour. That's all. Oh, you've been there one day, psych. Do you eyes on?
Oh my god.
You cannot do any on psych? Don't lie to me. I'll know.
Just a little bit.
No, has anyone done it? It's probably better if you've done psych. Have you done psych?
Don't lie.
You have? Like, you can't, it's just appearance and behaviour. Like, you've already seen it, it's half the task. Yeah. Okay. Someone else want to do speech, mood, affect, thought, and perception? Red jumper, you look like you want to do it. Everyone's going to say this. Next, red. I'm just going to keep going down. Yeah, he doesn't even say what his mood is, so you just say not recorded. Cool? Alright, perfect. What are we up to? So you're going to do from like speech to perception, and someone else want to do the rest next to you? Have you done psych? Yeah. Do you want to do cognition, insight, and judgment? Perfect. Good something to do. No, good. I like it.
Yeah, because judgment.
Anyone else confident of risk assessment? It's a really important skill to develop. Krishna, do you want to do it?
Oh, yeah.
Thanks, man. And someone want to get two. Someone want to come up with a diagnosis? Anyone? No. So far, you're doing a diagnosis. Any fun? Oh yeah, shit. Antonio, you're up.
I haven't done psych, Rob.
That's okay, you'll learn on the spot. Well, like I could have made someone do the whole thing, but so everyone's got like a little task. You'll get to watch the video twice in the actual OSCE, but we'll only watch it once since everyone has to do like 2 sentences of work. Does this have sound, Jen? Will this play?
It should, yeah.
I haven't always.
Chase. It's a sound, sorry. Which helps. Read the sound before we watch the video. So you should be able to like kind of pick a diagnosis just from the sound. I should have a good idea of what it is. Tell me when you're kind of done with it.
Is it?
I think so.
Is it?
Yeah.
Oh god. This is fun. I like it. It's a really good podcast.
Okay.
Short research. But also actually, it's just like stuff to be like, I'll link it to it. It's real good.
They're all good?
Yeah, it's real good. Like you like when they're in the hospital, you just listen to it.
Wait, what's this?
This podcast. And like you think on everything. Like you think on influence. For balancing.
Oh, cool.
Like actual influence stuff. Which isn't really useful now. But like.
All right. So for those of you he can't read. This is a guy who had bleeding out of his bum, and he has a history of bowel cancer. He's got cerebrovascular risk factors. He likes to have a drink, and he stopped drinking maybe for 2 days. Could withdraw in 72 hours. And he was kind of cognitively intact, so he was understanding the procedure and everything. So prior to coming in, he was A-okay. So now he's recovering from the anaesthetic, and he seems a bit agitated and confused. Please remember who did what task, because I have no idea.
My name's Dr. Ian Prescott. I'm not specifically wrong. I have to get out of here. Funny cats are trying to kill him. Yeah. Okay.
So judgy.
Well, can you sit down for me? Yeah, because if I could just take that, perhaps we should have a bit of a talk about that. Who are you and why are you talking to me? Well, I'm Dr. Ian Prescott, and I work here, and you seem pretty agitated and worried, and I thought perhaps we should try and sort out what that was. And you'd be worried too, but we're trying to do. Okay, can you tell me what's brought you to that conclusion? People are walking around in masks, and they've got green hats and uniforms, and they're trying to kill me. What made you think that they were trying to kill you? Because they said they were trying to kill me. I said he's not doing too well. Right. So, and you thought that applied to you? Yeah, of course. Yeah, okay. Right, where were the people when they said this? They were walking past, so I heard them clearly. How many people do you think you heard? I think there were about 3 people there, but only one spoke. Only one spoke. Okay. A male voice, or I went my bus. Male, I think. Male voice. And he said, I don't think he's going to do too well. Was he pointing at you or looking at you? No, I knew he was speaking. You knew he was talking about you. Yeah. Okay. All right. Just to change subject for a second. Can you tell me where you think you are at the moment? I'm not in a hospital. I don't know. Have you got any particular reason to be in a hospital today? No. Okay, because what I was told was that you actually been admitted this morning to have a colonoscopy. You are now this is the post-operative area. Yeah. So no, it's not possible. Well, my mum had a colonoscopy, and so I'm never going to have one of those. Maybe I'm here to test, but you definitely haven't had a colonoscopy. No. Can we speed this up? I've been here for hours. You feel like we've been talking for more than a few minutes? Okay. Out of interest, why would you think people would be trying to touch you? Oh, well, we just said okay. Is there any particular reason anyone would have a problem? I'm a bank manager. Right. Yeah. Okay. And what would be the connection there, do you think, though? I'm a bank manager. Right. It doesn't need much more than that. Do you like your bank manager? We won't talk about my bank manager in a chase. You keep looking off to the side, Chase. Yeah. Everything all right? Well, I want to get out of here. I want to get out of here before they come back. Before they come back and kill me.
Cool. All right, where did I start? I can't remember. Go appearance started somewhere here, right? Yep.
Appearance is just having black
That's it.
I was going to say,
Okay. And then sorry, just keep going.
and then behaviour is agitated, generally is compliant towards the end of its agitated. There was good eye contact, but very structured.
good eye contact. I suppose like the way I described it was sort of he was engaged, like he was kind of paying attention, but he was very distracted. He was just, his eyes were all over the room. So I wouldn't use the term good eye, and that's my opinion. But as long as you can justify anything, you say whatever you want in this. Anyway, yeah, that's like all the important stuff. You said he's agitated. I'd probably say it's like psychomotor agitated, just to kind of really hit on what you need to. And probably like one thing which they try and kind of give you marks for is they don't want you to just like remember a list of things to tick off. So if someone does something really obvious, like he's trying to wear a pillowcase, like just mention it, because they just want to make sure that you're not just like remembering a list of 10 things. Same as if someone's doing, if a simulated patient's doing something odd, just like please mention it. You probably get a mark for it. All right, let's go on to speech. Somewhere up there, yep. Yep, cool.
Really nice, agitated, suspicious,
yep.
range, reactive,
Do you say the congruent with his mood that we didn't ask about? It's probably correct, but yeah, I just wouldn't say it's congruent when we don't know his mood. That's all. Yeah, that's good though. It's perfect. I'm just being very picky. Me. Sure. Thought?
Schemes more. Content is form of disorder. That's a very good.
So you say there's no formal thought disorder?
That's a very good.
That's a thought content thing, right? There's no formal thought disorder. Yeah, delusions. I'd also mention ideas of reference because he saw some guys that probably work at the hospital walk past him and they said, oh, he's stuffed or something, and he thought they were talking about him for no reason whatsoever. Just want to mention that as well. But good. Perception? Yeah, no perceptual disturbance. Perfect. That's very good. And who else do I give the rest to? You? Cool.
Yeah. Insights, not very much at all.
Yep.
Judgment or cognition are not formally assessed, but he's alert. Didn't assess
Alert. That's what I was picking up.
Huh?
He thought the interview, like he said, he thinks the interview had been going on for like 2 hours, been going on for like 10 seconds. So I'd say he's not, he's just about No, he was awake. It means like you're attentive as well, you have awareness. But yeah, sure, okay. So his GCS was 15 or 13 or something. Good. Okay, cool. But he like wasn't orientated to like place. He didn't think he was in a hospital. He couldn't remember having the colonoscopy, and also he had no idea about the flow of time whatsoever. And it's hard to assess if he's orientated to person, given that he's never met Ian Presnell before. But no, that's very good. Good. That's a lot of stuff you have to infer, so it's a bit tricky. I mean, alert kind of implies that he's with it, but you're just trying to say that he's like conscious, is what you're trying to say. I don't know. I said he's differently in psychiatry. Fair enough. No, like, as long as you explain what you say, you're fine. Cool. So you said insight was poor? Yeah, because he's got like persecutory delusions, so doesn't really know what's going on, and he doesn't think there's anything wrong with him and he wants to leave. Cool. And judgment? Poor. Yeah, based on the same reasons that he's got these delusions and all that. All right, excellent. What do we else do? We did a risk assessment somewhere. Krishna? I'm looking at you. Cool. Tell me about his risk. Yeah, he also has low insight, but yeah, cool. Just sorry to keep interrupting, but I'd probably also mention that like it wasn't asked, like, do you have suicidal thoughts? Which is appropriate. You don't just ask random delirious people like, do you want to kill yourself? It's a bit an odd question, but just I'd probably mention that it wasn't asked. It's probably low, correct? Yeah. And just remember, he's having really strong delusions that people are trying to kill him. So people like defend themselves, and I think that happens. So if someone looks at him a bit funny, he might just like punch them or something. That's a risk. But he doesn't want to kind of go around killing people. Yeah. 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 Wearing a pillowcase.
No way.
Cool, I agree. So when you do a risk assessment, there are kind of a few things. So you mentioned like financial and like other people about substances and stuff like that. There's sort of a bit more the airy-fairy ones if you want to be like very clever. The ones you need to like kind of pick up on are harm, so harm to self and others, which you did. Suicide, which you did, which is good. You mentioned absconding, and the other very, very important one is adherence. So like compliance. Is he likely to be compliant to treatment? We'll get to that when we get to diagnosis, but like, do you think that he would be compliant? Doesn't matter what the treatment is? No. I suppose my kind of thing would be like, it's a bit more moderate, because he was very polite to Dr. Presnell, like he wasn't telling him to like get lost or anything, but also he has no insight and stuff like that, so he doesn't really want the treatment. So you could make a case there. No, that was good. You covered just about everything we needed to. Someone's going to do diagnosis. Oh, there's a hand up. Go.
I just have a question. If you don't actually ask about whether someone's going to hurt themselves, can you really?
No, you can't. Correct. But you can only. It's a video station. But yeah, the psychopaths are like they're a bit stupid because like you don't sit there for 8 minutes with someone and get their whole life story and understand them as a person. You need 2 hours or something. So they're very contrived, our OSCEs. And same as the history stations, you absolutely fly through things, and you know they're written in such a way that you can as well. They're very simple.
So would it be appropriate to say it was not said or could you just go with because of X, Y, and Z?
Well, then you'd say it wasn't explicitly asked or stated. You didn't express any suicidal ideation, but we can infer from you got to make some kind of call on it because you can't just say I don't know. But yeah, that's a very good question, and I suppose a good reminder whenever you do a history, please ask. You should do a suicide assessment on everyone, but obviously this guy's probably not going to kill himself. So it is quite low risk. All right, diagnosis I gave to someone. So.
So, I think he's delirious.
Cool. Why?
He's pretty fucked up.
He's pretty fucked up.
So he's had
Congratulations.
surgery, a colonoscopy, whatever.
Yeah. Is that GA? Cool.
Yeah.
I agree. It's very common. It's the right answer in this case. But anything else you could think it might be? Things that like there's reasons why it's not. But is there anything else you would think of in this guy? Yeah, the alcohol. That's right. So 72 hours is kind of the classic withdrawal period. So if someone doesn't drink for 72 hours, so it doesn't say he hasn't drank for 72 hours, but it says that he has 2 alcohol-free days per week. And they might have been prior to coming in. So once again, that's not just some random crap Ian's like written in there because he wants to like add flavour to this guy, but like it matters. The other thing I consider is like a vascular dementia, given he has all these factors, and this is a kind of an acute thing, so it could have been cerebrovascular incident of some sort. And obviously stuff that's really unlikely, drugs and a psychotic illness presenting at 52 after a colonoscopy. That's really good. I think like that's my mental state exam. I got to watch it twice, so I cheated, but you get to do that in the OSCEs as well. And the trick to this is like it's almost guaranteed this will be an OSCE station, like guaranteed. You'll have to do this kind of risk assessment. So, and they're the same for each patient you meet. And you should have a rough idea of what the kind of typical OSCE state, typical mental state will look like for someone with depression, someone with bipolar, someone with schizophrenia, maybe even someone with borderline personality disorder or something like that. And if we were all to do this, we'd probably get slightly different answers, but the examiner marking sheet doesn't actually have like words on it. It just says whether they do it competently or not. So as long as you kind of cover everything and at least justify it in some kind of reasonable way, you'll pick up all the marks. And mental state exam is kind of an easy station. You should all be very confident going into it. Does anyone disagree with anything that's on there? We can have a chat about it. Cool. This is my risk assessment, which, once again, as Christian did very well. He went into a few other things, but these are kind of the core things you should cover. Anything I want to talk about here? Not really. So yeah, just give reasons for everything. I suppose at these stations, my strategy would kind of be the first time I go through it, I'd listen to what they're actually saying and try and get a diagnosis and a hint of where this is going. And then, because we're always going to get like a very typical case, you're not going to get some diagnostic uncertainty dilemma thing, 4-minute video. You can kind of fill in the blanks without even listening the second time. So if it's someone with depression, their mood might be depressed. They might be wearing black, something like that. They might not be making eye contact, things like this. So you can use your brain to kind of, these are a game, have fun, play them, do well on them. Right, yeah, diagnosis. Same as Antonio beautifully said, the guy was kind of fucked up or whatever. So a deficit in awareness and orientation. It was acute onset, hyperactive delirium. Could it be because of the alcohol? He's probably got a good level of functioning being a bank manager, so this is kind of out of character for him. Differentials I consider, as I said, vascular dementia, psychotic disorder, substance abuse, alcohol withdrawal, and a picture of delirium. You guys covered almost all of that, which is really good. You still got ages to go until the exams, like 2 months, so should be very confident having done that. Thank you. There's my email. If you have any questions or whatever, or confused, you please ask me. I'll answer. It's 8:22. Let's go.
How do I